Here we go. Welcome to the TelePT Connections podcast. I'm Daniel Seidler, and my very special guest today is Emil Berengut. Emil, welcome.
Thanks, Daniel, and thanks for having me.
My pleasure. I'm glad you could be here. This is it's really exciting for me to be able to talk to you, and we have a lot to talk about.
Yeah.
You've been not just a PT, but you've been a healthcare provider for 25 plus years or so, right?
Yeah.
Give us a quick rundown of how you got here and where you are today.
Sure. Started my career in Baltimore in the 90s, working in chronic mental illness and addictions. Went on to get my social work master's, did that for a few years. And then from there, I went back to school. I wanted something with, because usually people ask me why. So one of the beauty of physical therapy is that we have really great ways to measure outcomes in a very objective way. And so I was looking for something like that. And from there, I went to hospital special surgery. I completed the orthopedic residency there, moved on to Memorial Sloan Kettering Cancer Center. I worked there for a few years and had opportunity to work on the first national oncology physical therapy residency. That was also the time when I was able to sort of gain the most in terms of publication and produce the most, I should say. Published a few papers, did some talks at CSM and ACRM, and I'm currently at New York University at the Student Health Center, where I manage the PT department. And of course, I only represent myself, not employer, in everything I say.
Disclaimer. All right, now you can say whatever you want, Emil.
Sure.
So when you say you like the objectivity of PT, I mean, some people could potentially argue that we have a lack of objectivity in our measurements. Were your thoughts confirmed? Like when you finally became PT, what were you thinking at that point?
Yeah, that's a really good question. I think as for most of us, when we first graduate from PT school, the objectivity tends to focus on very concrete measures, things
Sure.
like range of motion, strength, whatever it may be.
Yeah.
The more I did this, the more I thought the focus for me personally shifted onto objective measurements of function. And it became more and more important as I started to work with folks who had a ton of impairment and really had difficulties with things like crossing the street, picking up their groceries. And in that sense, you really get to see the impact that you're having as a physical therapist in someone's quality of life.
Yeah.
So in terms of objectivity, you can measure quality of life. You can measure their ambulation speed as it relates to their ability to cross the street to their grocery store.
Sure.
Very pertinent in New York City.
Yeah.
And since all of us live in some sort of a walk-up here, you can either walk up to your fourth floor, apartment, or you cannot. And so there's a lot of objectivity there.
Right. I forgot, by the way, I had a whole intro planned, and part of it was to say fellow New Yorker Emil Berengut. Yes, exactly. And there are definitely some unique challenges to living in a city like New York, which I guess is, as a PT, it's interesting. You kind of take it for granted when you have conversations with patients, right? You're like, can you get on the bus? Can you get up and down the subway stairs, right? I mean, that's something that always comes up in your functional, I guess. I mean, I never really thought of that. That's an objective functional assessment in itself, right?
Yeah,
I guess that's where you get at. Yeah.
It's like, here's a conversation I've had many times. Is your bus kneeling or not?
Great question. That's exactly, that matters.
That matters.
For a lot of people, that really matters. I mean, I think, you know, nowadays most of the buses are, I think, you know, but years ago, that was, you had to be able to get up a pretty high step to get onto a bus. And that was a big problem for people who had any sort of disability or impairment or a little bit older. Yeah. You're the director of the Student Health Physical Therapy department at NYU. Yep. So I think you mentioned to me before that you have been strictly telehealth for 16 months.
Yeah, strictly telehealth happened virtually overnight.
Amazing. Yeah.
Like most of us, in most PTs, most administrators scrambled to find out what the laws are that guide our practice.
Sure.
Scope of practice, insurance reimbursement, things that kept me up for many, many months initially, especially when things were changing.
Let me cut you off for a second, because I'm thinking back to that time, and I was consulting at that time, doing a lot of consulting, and I was getting exactly those questions. And what came of it is, end result is that every payer paid, right? And basically it was a free for all, meaning you could do telehealth however you wanted.
Right.
I can't imagine the amount of stress that you were going through in terms of like, is this okay? Like, right? Meaning like, are we going to get paid?
Yeah.
Do we have to follow certain parameters? You know, can we use Zoom? Right? I mean, are those the considerations at the time?
Absolutely. And there weren't really any firm answers. The biggest thing on our mind was scope of practice. Okay. Because the university has 50,000 students. Many of them are all over the country, all over the world.
Yep.
And we worked essentially on a list, a state-by-state list of which roughly fell into 3 buckets. States that allowed virtually unlimited telehealth.
Yeah.
Had no regulations in place. States that at some point developed some sort of limitation, like it had to be a known patient, it had to be.
Oh, right.
You know,
the origin, originating location or distant location site.
And then, states like Cali, which it was just like flat out, basically, no, like you have to be licensed in Cali.
Right.
And so we had to essentially combine this data with the data on where our patients were located.
Right.
And if we were unable to provide care in those locations, we had to get really creative about what could we actually do and what constitutes skilled physical therapy care, what is covered by scope of practice and what's not.
Sure.
And in most cases, we were able to find providers locally.
Is that what you did? Just
Yeah.
manage the care of the patients. And just to clarify, this is NYU students who were not allowed back, like campus was closed.
Campus was closing, yeah. It was basically
closing, right? And you had current patients. They were being sent to their home state, essentially.
Right.
Is that what happened?
Yeah.
Yeah, and you had to figure out how you're going to continue their care.
Well, so like I said, in some cases,
that's so interesting. Yeah.
Yeah, I've never seen so much gray area in my entire life. We're in healthcare, we're so used to everything is regimented, compartmentalized, and there's a regulation for everything, right? It's everyone's headache. And then when we find ourselves in this like kind of Wild West, it's terrifying. And there's the toughest part was, I am a healthcare provider. I genuinely want to help my patient.
Yep.
Has nothing to do with getting paid or not getting paid. It's a bit of a unique situation at the university. The emphasis was really getting the care to the patient beyond any reimbursement.
Yeah,
right?
Very pure intentions, right?
Pure intentions. Do I let this patient who may be having a pretty severe condition and they might be post-operative, you feel like if they don't get a chance to speak to someone, they might get like a flexion contracture. This is a 21-year-old who may never walk correctly if they don't get some guidance.
Yep.
So thankfully, it all worked out. Like I said, we were able to find, providers. Most places, once we were able to connect them to like a large healthcare center, like, I don't know, Mass General or like Massachusetts, I'm just thinking off the top of my head. In California, Kaiser usually was the, go-to.
Right.
Once we were able to connect them, we stayed in touch with them via sort of secure messages. Just we changed our role from what we're used to more of a advisor.
Yeah, a care management advisor.
Care management. Yep. So so it worked out. At the end of the day, everyone who left was able to get the care, and then the folks who stayed. So I'm sure New Jersey was really easy to get temporary license. Sure. We got that email. It was virtually like overnight. It was the easiest thing ever.
Yeah.
So people who stayed in New York, New Jersey, which was vast majority of our folks who didn't want to leave because they didn't know if they'd be able to come back.
Sure.
We were able to continue working with them without any difficulties.
Yeah. So you ended up treating the majority of your patients via telehealth. Right? Well, all your patients, you can continue to treat them. What'd you learn from the experience?
Man.
And it's not over yet, right?
Yeah, it's not over yet. Yeah, beyond all of the regulatory stuff, I learned that we can be more adaptable than we realize. I learned that we ought to be better at using our verbal skills and our communication skills.
Sure.
And not, especially in times when you can't rely on your hands or even even in your eyes, as much as we're used to and as much as we're trained. And I learned that actually, in terms of compliance with home exercise, I'd estimate we probably are in the 85% to 90% range on telehealth, whereas previously everyone knows the stats. It runs in the 20s and low 30s.
Why do you think? I mean, why do you think why do you think patients are more compliant with their home exercise program if you're seeing them through telehealth?
I think it's probably a combination of things. Number one, as many of us often do when we prescribe home exercise programs, we don't necessarily consider the barriers they might experience getting to the gym, getting the equipment, getting the schedule they need to actually effectuate the home exercise program.
Right.
By working with them in their home, understanding what equipment they've got, in place or don't have in place, that's most often the case.
Yeah.
What's their schedule like? We were able to help them overcome these barriers to traditional issues with sort of non-compliance. Sure. Right?
Yep.
You're
more in there. You gain a better understanding of their everyday life and their resources, I guess, right?
Yeah.
And challenges.
So, number two, we're in their environment. Say somebody's coming in with neck pain from being on a computer on their laptop for 10 hours a day.
Yep.
I can see them at their workstation. I can use a secondary camera from their phone to picture them in profile. I can make very specific targeted recommendations to exactly how they need to move, what they need to do with their chair. And then, finally, a part of it was a lot of folks, certainly in New York City, were stuck at home. They had nothing better to do. So
so the pandemic was the cause of them doing the home exercise program. Nothing better to do. I'll do my home exercise program.
Sure. There's a paper in there somewhere.
Yeah. There's definitely something to that. This is a paper in there, right? That's how you think about it, right? Yeah. So, and do you think you'll continue, like in your program, do you think you'll continue to use telehealth and probably like convert to more of a hybrid program for a lot of patients?
Yeah, so the Student Health Center just had such amazing success and such positive response to the virtual model that they're making a commitment, and we are making a commitment at the PT department to continue to offer hybrid services. In addition to providing clinical services, we were also able to offer things like stretch snack, movement ergonomic assessments for people, and really step out of our role of, waiting for the referral, insurance, and step into a more proactive role where we got a chance to prevent issues from happening before they escalate enough for someone to see their physician.
Yeah. So do you work with other departments in doing that? Or I say other departments, I mean other specializations, other specialties.
So for this specific thing, we did work with other parts of the university or the student health center, but not necessarily other on the medical side.
Right.
So for example, we put together a program with the health promotions office, where we were able to promote it and offer this program, directly, sort of direct to consumer. And that worked out really great. Had really good response. People made it a part of their day, part of their lunch hour to participate.
That's
really
great.
wanted to break it down into, parse it into bite-size, achievable kind of movement goals, right at their desk, even if they're working at home.
Right. So you have, I mean, it sounds like being the student health physical therapy department, you have, first of all, it sounds like an attentive audience, and secondly, it's a closed, I don't know, closed environment, or just like closed population, right? So that gives you, it sounds like it gives you some liberty and some freedom to really be able to implement programs.
Yeah, it's a closed ecosystem. I think of it as
that's a good word. That's what I was looking for. I like that.
You figure we've got 50,000 students, probably 20,000+ employees. It's a population, small to medium-sized town.
Yeah.
That happens to be located in New York City. Yes, there is a lot of really, I would say, rewarding opportunities that don't traditionally come across the sort of the traditional purview of physical therapy in more traditional settings. So, and I'm very grateful for that.
Right. So, do you, and it sounds like you're implementing some very proactive programs, preventative programs. Can you speak more about that?
Sure. So, the pandemic kind of gave us the opportunity to, as I mentioned, to really understand on a very granular level what our patients or potential patients or colleagues are experiencing. Everyone was being stuck at home. Everyone was at their electronic device for hours and hours and hours. As they say, the productivity for many people has never been higher because that's all we had is work.
Yeah.
There was really a lot of apprehension about leaving the home, and we perceived sort of a bit of a disconnect between the desire to move and really knowing how to move safely. And so because of that, we were able to put together programs that helped with workstation setup. Everyone scrambled, right? So everyone threw a laptop on top of a pillow somewhere, and that was the home office.
Yeah.
And no one had access to the gyms. Everything in New York City was closed. So everything we were going through, we knew that the folks we work with and the folks we were trying to help, they're going through maybe to a larger extent. So I knew exercise equipment was impossible to order, right? It was like months waiting. So how do you make the best of it? I'm a PT. One of the things that I enjoy about this profession is that we get a chance to MacGyver.
Yeah.
So how do we leverage things we've got at home to prevent an ache, neck ache or back ache or whatever it may be, from turning into a pain, from preventing you from having to go to see a physician, even if it's a telehealth visit, and potentially escalating into a bigger and bigger problem. So this was our opportunity to field test that. I think, I hope we were successful. I think we were able to assist quite a bit of people.
Was your staff up to the challenge?
Yeah, I think I have very talented staff who have a natural gift for getting people really motivated and jazzed about movement.
That's huge.
And so I'm very fortunate to have these colleagues. And like you said, it's a bit of a microcosm. And I don't know if this model would have worked for everyone, but it worked for us.
Well, I think it's a great model for similar environments, university campuses and similar ecosystems, right? But I'm just thinking it could possibly be applied to, you mentioned small towns. So if you're a physical therapist in a small town, why not do programs like this? And why not, learn from your experiences and be able to implement population health programs in, populations of 100,000 people or less?
Yeah, small towns or areas that are geographically remote, areas that don't have access to skilled PTs. I've worked with, I've taken courses like continuing ed courses with people out in the middle of Texas. And, I remember this gentleman, he said he's got a practice, which was, by the way, which was like 8,000 square feet. And it was just him, basically.
That's nice. Space is a little bit cheaper in rural Texas than in downtown Manhattan.
But he said he'd have patients drive like 3-4 hours to get to him.
Sure.
And so, you can connect people in geographically desperate kind of regions, connect them, bring skilled care into their home, don't have to drive, you don't have to go to the gym. And most individuals coming from no physical activity would benefit from even 5-10 minutes of physical activity per day if they're guided appropriately. And who else is better to do that than physical therapists who are trained in red flags, exercise prescription, functional limitations, and all of these things. And we can do that not just on when it gets to the pathological level, we can do that even before that.
Right. So how do you, we can do everything. We can do all these programs. How do you motivate people to add exercise to their daily life, particularly people who just don't want to exercise or don't understand the value of it or think it's just not worth it?
Sure. So for me personally, and this is the approach I've taken, so I've relied on my experience in social work, and I spent years working in addictions. And what I did there was, at the end of the day, you're just trying to help someone change behaviors. You're trying to motivate them.
Yes.
And for years and years and years, I used a combination of motivational interviewing, cognitive behavioral techniques to help effectuate that change. And I use a model called Stages of Change, which was developed in health psychology. When I was undergrad, I had a chance to be a research assistant for one of the founders of the program of this theory. His name is Carlo Di Clemente. He's a clinical psychologist. And what he taught us was that essentially whenever someone changes behavior, they go through stages. They start in pre-contemplation, where they don't think anything is wrong. And, traditionally used to be called denial, right? And they progress through a series of stages until they get to things like maintenance. And that's where you're actively engaged in this change behavior. The model was originally developed for smoking cessation. There's tons of research out there in applying this model for other health change behavior. And the idea there is that you have to understand where someone is in these stages, and cater your intervention precisely to their level. So an example would be someone who is in pre-contemplation, doesn't think anything is wrong. It wouldn't behoove us to give them a detailed, 2-page exercise program with sets and reps and weights and equipment. Probably not going to do it. What you do instead is you provide education, you help them make them decisions, you help them tip the scale towards why they would benefit from this behavior change. By the way, this applies to home exercise too, not just
PT. I mean, and it's so interesting you mentioned that, because I, as a PT, I never formally really thought, I never consciously thought about that, but I will always assess a patient as to, like, is this someone who, like, they come to me and say they want to run a marathon in 4 months. I know that person they want a full program. They want to know the basics. They want to know progressions. They want to know how to get to that, their 26-mile run. And on the opposite end of the spectrum, there's people who come to physical therapy. Yes, why are you here? And they say, because my lawyer told me to go to physical therapy. That patient is not going to do 10 home exercises twice a day.
Sure, exactly.
So, and obviously it is a spectrum. So I think we all do that sort of assessment, consciously or not, right?
Yeah, and so and what you were describing is essentially what I've encountered with successful physical therapists who establish really good rapport with patients.
Yeah.
And like you said, they may not formally, say this person is in contemplation, this person is in preparation.
Right. I never use those words.
That's
ever.
fine. We don't. Jargon doesn't help us. The framework does.
Sure.
And so when you establish that rapport, and with experience, physical therapists are able to understand approximately what this person is ready to do, and that's what this is readiness to change, right?
Yeah.
That's another name for this. And then you effectuate an intervention according to their readiness to change. And like I said, there's tons of data that supports this. There's other more in-depth things, like you said. There's psychosocial factors, there's financial factors, there's family support, lots and lots of other things that we can talk for probably hours about.
Yeah.
But at its core, in terms of motivation alone, that is the framework that I use, and I found it to be, for me personally, very successful. This is a model I share with when I get opportunity to teach PT students, when I get a chance to talk to other physical therapists, and thus far, I've been doing this now for 12 years. I've been very, very happy with it.
Yeah. Have you heard the joke? How many psychologists does it take to change a light bulb?
No, how many?
The answer is 1, but the light bulb has to want to change.
Oh yeah, absolutely. Yeah. It's funny because there's this, there is definitely, much like in physical therapy, also in clinical social work, there's that same thing about, whenever you talk about someone, any behavior change,
yeah,
stopping smoking, stopping, drinking, or whatever it may be,
sure.
There's this idea that if the person is not ready to change, there's not much you can do. And there's a component of internal motivation, agreed.
Right.
But there are circumstances, I believe, in every case where whatever someone's level of motivation is, that person is in front of me for some expert care.
Yep.
And I'm going to do my best to set this person up for success. And if that initial program may only be, doing this at their computer station every hour, and that's all they're ready to do, but I can start with that.
Absolutely.
And in most cases, they will come back to me and they will say, I got this feels great. Is there anything else I can do? Of course.
Well, you never ask, right?
But you never ask. And that's when you introduce more and more sort of iterative exercises.
Yeah. That's very high level of you. Really recognizing that you kind of have to tease it out of people in a way, and kind of, if you do hold back, they will actually come back. Most patients will actually come to you and say, what else can I do? So you said you teach at NYU. What do you teach?
Sure. So I help to teach a class every spring called Principles of Exercise.
Yeah.
I work with 2 NYU professors and another colleague, another NYU grad, in teaching this class that prepares NYU students for the Cscs certification before they graduate.
And they're all required to take the CSCS? Is that part of the curriculum?
Yeah, they're required to take the CSCS. I see it as, there's sort of the advantage of having the certification, but I always try to make it, I think that's just the PT in me, I always try to make it as practical as possible.
Yeah.
And I see it as an opportunity to introduce or develop the strength and conditioning knowledge in physical therapy.
Yep.
And I know it's not always consistent in every curriculum, but I do think that there's a wealth of strength and conditioning research that we all benefit from knowing and applying to our patients, whether that patient is, a 10-year-old or a 90-year-old.
Absolutely, all ages. I totally agree. I think that exercise is often underdosed by PTs who don't have a good level of understanding of how valuable it is. And I remember often seeing PTs just not giving their patients enough volume, enough resistance, enough intensity when the patient needed it. And obviously you have to, you have to be cautious and safety first and do no harm, of course. But it's also, you're doing a patient a disservice if you're underdosing their exercise. So I would imagine that having a CSCS is something that would make certainly a PT coming straight out of school, give them more confidence in the safety and the necessity of prescribing more exercise, essentially.
Yeah, there's sort of the traditional disconnect that's been, I think many people have struggled with this. When we get out of PT school, we think about the traditional 3x10 model, right? 3 sets of.
Sure.
And then you look at, and so we tell the patient, we do this to improve your strength. Then you look at the sort of strength and conditioning research, and that's really not the model, not the generic model that's validated, right? You have to do testing, you have to understand what their current, level is, their methods that are developed, and these are very similar methods. You can apply the same methods to determine the strength of someone who's elderly to someone who is an active athlete. You have to adapt it, but that's our job as, as licensed professionals to do. But ultimately, I love to bridge the gap between the clinical field and the sort of the other fields, other strength and conditioning fields, and other, neurology, cancer rehabilitation, whatever it may be. I'd like to bridge those gaps to help the patient at the end of the day meet their needs.
Yeah, and I think the most valuable thing for most patients and that we can provide is guidance in an exercise program. As simple as that sounds. We often think of as our manual techniques and our modalities as being essential tools to what we do. And, in many cases they are, but at the end of the day, the patient's on their own, and, when they're done with therapy, they need to be educated. They need to understand the mechanism of injury that got them to where they are, or why they have a disability and what they can do about it. And ultimately it's about movement, right? And everyday activity. And the best way to enhance that is through exercise. So that's where that's our greatest value, I think, to our patients.
Agree. And that's where we also have the opportunity to really demonstrate our value and our training and our education.
Sure.
For in healthcare and outside of healthcare.
Yep.
There are a lot of different professions in the same field. And many of our patients really struggle to understand the difference between all of the different people who are involved. And the more we can make the goals relevant to the patient, and the more we can rely on solid scientific evidence in why we're doing this, I think the better we'll be able to demonstrate our value to just the general population, not just the patient.
You've talked about population health a bunch already, and you know, some of the things that you're doing. You're also working on a master's in health administration. Is there a tie in there?
Oh, it is a tremendous tie. You know, I started the program before the pandemic.
Yeah.
And we spent sort of hours, semesters upon semesters, papers on papers, writing about all the shortcomings of not just American healthcare system, but others. And one of the toughest, biggest deficits was, population health. And that includes everything from vaccination to physical activity. And then pandemic hits, and we're living these kind of, I wouldn't even say worst case scenarios, these scenarios that no one would ever imagine. And virtually every single shortcoming of the system was laid bare. Inequities in care access, inequities in preventative medicine.
Yep.
All of these issues that this, the virus and our response to it just helped to bring to the surface.
So, So what do you see as solutions for that? I mean, you know, we all know the last year and a half has been a shit show in many ways. Yeah. But so what do you see as solutions? Like, what could we have done better? More importantly, like let's talk about that. What can we do for the future?
Well, let's get specific, right? We're physical therapists. We're talking about population health.
Yeah.
So our training is in spans every single system. We're trained in exercise prescription. We're trained to educate our patients about exercise. And we're also trained to do things like, recognize flags. I believe this makes us optimally positioned to be at the leading edge of doing things like promoting physical activity in the population. Every single, week I see, if only people walked this much. I just saw something, people who exercised prior to the pandemic, sort of like 30 minutes a day, had much better outcomes than people who didn't, right? Perfect example.
Yeah.
You look at these shortcomings, who else, name a profession that is right now positioned to actually get folks to move and has the background to do it?
Right. Same medical background combined with exercise and movement. There's not. Right.
There isn't, right?
Yep.
Physicians are great at what they do, but physicians don't have the time and don't really have the training in exercise prescription.
Oh, I mean, I can't tell you how many patients I've seen over the years who were prescribed by their doc. You're overweight, you're pre-diabetic, you need a better diet, and you need to start exercising. So they cut out carbs, which they don't really even know what that means. They don't go to a dietitian. They cut out carbs, and they start walking on the track, and they do a mile 3 days in a row, and suddenly their knees flare up, and because they're 50 pounds overweight, and they should have been prescribed physical therapy.
So we are in the role of knowing how to reach large groups of people and help to make that increased physical activity a reality. Now, it's not easy. It's not an overnight thing. But if anything, what COVID taught us is that when there's a will, there's a way. And so for a smaller sort of private practice, it could be finding a population of people in their community and providing some sort of a, physical activity, stretch snack classes, or maybe they could be virtual. They could be, They could do just assessments and figure out what their current fitness levels are, right? And just providing that feedback. Remember, going back to that sort of motivational kind of techniques.
Yeah.
Larger healthcare institutions with more resources, again, can they potentially seek funds to work with their community to prevent more troubling things from happening, things like stroke, things like diabetes, things like high blood pressure through physical activity, setting up sort of movement labs, setting up portable exercise, I don't know, putting some stationary bikes into a truck or something like that, playing some music. Let's learn from successful models that exist out there, right? Things like Peloton, right? And let's make it more accessible for everyone. Private industry in some ways has done tremendously well in being able to do user research, to package these products in a very attractive way, but it's not accessible to a lot of people, right? There are very few of us who can afford a $2,000 bike and a $40 a month subscription. But at the same time, we spend, as a society, we spend 1/5 of our budget on healthcare costs.
Sure.
So think about the return of investment on just a small amount of that to simply get people to move and walk 30 minutes per day.
Game changer.
I think that, and I think that physical therapists are the best. It is the best profession to make it happen.
Yeah. I mean, the challenge is the implementation of a program like that. Of course, whether it's in a community or even with a specific patient, like a micro or macro level. What have you seen work on a macro level? And do you think that technology will play a role in it? I mean, it seems like on a larger scale, you probably do need to create efficiencies in some ways.
Absolutely. I can tell you a very simple thing, and New York City Parks and Recreation. People don't know this. They've got phenomenal fitness programs that are very low cost. And they cost for senior citizens, if you're over 65, it costs something like $65 a year. Okay,
for what?
Just nominal. So
what do you
gain
get for
access,
your $65 a year, right?
Yeah, for 65. So there are gyms all over New York City, including pools, gyms with exercise equipment, and most importantly, they get access to free and to low cost personal training.
Really?
Yeah. Now, I'm not saying personal training is the key to success here for millions of people.
Sure.
Right?
Yeah.
But I am saying that you can have a low cost solution that enables hundreds of thousands of people every year access to physical activity.
Yeah.
And think about for every dollar New York City that never has any money, for every dollar they invest in these programs, how much does New York State, New York City gain in terms of savings in healthcare costs?
Sure.
Programs like this can be scaled. You're 100% right. Implementation is always the toughest part.
Yeah.
But I think we really have to think outside the box here. And instead of, we got really good at managing sort of patients once they come to us as PTs, as our colleagues, physicians, etc. But let's think about how can we get people not to come into the clinic? How do we intervene with someone who maybe is at risk for having a stroke? How do we intervene with a large population? Let's say I live in the Bronx, right? So it has some of the worst rates for stroke and cardiovascular health in the country, right? So how can we figure out ways partnering with healthcare institutions, with like healthcare systems, with state and local governments, and creating programs that help to improve access to low cost,
Right.
accessible physical
So
activity.
who do you see leading the charge on things like that? You and me, or the mayor of New York City, or I mean, like, who?
Yeah, I'm happy to do it. I'm happy to do it. No, realistically, this is what has to happen, right? A lot of these changes. So again, it can happen from ground up, or it can happen top down. If Medicare tomorrow decides to reimburse preventative medicine better, I guarantee to you things will change across the board, right? For millions and millions of Medicare recipients. If state Medicare administrations decide to reimburse preventative medicine differently, same thing. So that's the top-down sort of
money talks is what you're saying. Yeah.
But we don't have to wait for that, right? As I mentioned before, there is smaller projects can be run through large healthcare organizations or even medium-sized healthcare organizations. Really does not take much. And on a very small scale, and I know that there are private practices who already are doing this. There are people who go out and do screenings at little league games and games.
Or health fairs, or
absolutely,
or senior centers.
Yeah,
absolutely.
I'm not reinventing the wheel here. People already are doing this, but I hope that in the future, many more folks will be deliberate and take the chance and understand that just how much good we can do by taking a proactive approach.
Yeah, no, that's great. And I think, your point is, how do we actually, it's a double-edged sword, because it is a little bit of, it's de-incentivized essentially. And you said it yourself, how do we prevent people from coming to us as patients, right? And we go out and we do preventive programs or proactive programs. And the real answer is that the real question is, what is our purpose? Is our purpose to help people get better once they're hurt? Is it to make money, or is it to actually improve the overall health of a population? And I think, each practitioner, each individual has to look themselves in the mirror and ask that question.
Agreed 100%. It's not for everyone. It's not everyone's goal. And some people, they say, I want to be the absolute best, manual therapist for my patients. And I love it when I apply the right manual technique and the patient gets up and they feel awesome and they say, you got, magic hands. Awesome. That's great. I do think that for many physical therapists, there is a lot of room, a lot of space in improving population health. You asked about technology. Technology can play a tremendous role. There are, just look at everything Apple Watch has been doing with things like remote patient monitoring, arrhythmias. Apple, Google, all of these places, they're collecting billions of pieces of data on all of us. Can we use this information to create meaningful change in people's health, right? Stuff that's actually based in science and evidence. And that also happens to look nice and fun to play with.
Cool design, absolutely. I mean, that's a big part of it, the form and function, right? It also, of course, brings up the issue of privacy. How many is your health important enough to you to give up some of your privacy? Because essentially, if Google or Apple is collecting data on your movement and your activity, which they are already, right? How much of that information do you want them to have, or do you want to allow them to have, if it benefits you, if it's to your benefit? And, you know, that's like a lot of other things. You know, do you want, because I imagine that if my iPhone watch, or my iWatch, whatever, Apple Watch, you know, detects that I've tripped several times today, or I've lost my balance several times today, I'm going to start getting advertisements for physical therapy, or for, you know, from a local physical therapy place. To some people, that's really creepy. To some people, that is the natural progression of where we're going with technology. And that's extremely helpful. So, you know, I think as a society, we have some decisions to make, but also individuals probably have some decisions to make too, as to how much intervention they want in their life.
Agreed 100%. There are lots of ethical challenges in this. I would take the flip side of that, the ethical dilemma that you pose. Mm-hmm. And imagine if your watch was able to detect the beginnings of Parkinson's.
Yeah.
And imagine if, and imagine if, less so than directing you to, let's say, a local PT or whatever, maybe it would, with consent, alert your primary care provider.
Yep.
Or maybe it would provide some information about, you know, maybe seeking out additional medical evaluation.
Sure, even something as simple as, you have some signs that have led Apple Health to believe that you may have some early symptoms of Parkinson's. Here's some information. And they lead you to like the Fox Foundation or whatever it is.
Exactly.
So that you can do your own research from there, or, you know, and
whatever
you get to decide, give me more information, or stop texting me. Yeah.
Same thing you can say for things like, you know, I've heard probably most of, or many of my family members who, you know, go to the physician for their annual visit, and they say, you know, I'm pre-diabetic, or I'm diabetic. Prior to that, they didn't know this. They could have essentially gone into, could suffer really severe consequences, and they have to wait a year, maybe if they go every year,
to
get that information. So, like I said, it can be used for, technology can always be used for complete evil, right?
Yeah.
It can be used for sort of middle of the road, gray area kind of stuff, maybe selling you the product you need, or it can be used for good. So I think it's up to us. I hope we as consumers, as people who wear these watches or have these phones, have a bigger say in deciding what we want to share. Yeah. I hope that corporations and other sort of stakeholders consider that more carefully. I think at the end of the day, it could be a win-win for everyone.
Yeah, I mean, you know, you have to believe and hope that their intentions are good. There are certainly people who believe in every conspiracy theory under the sun and don't want to accept that at all. I personally am pretty much, for the most part, for that. I am, you know, I would like to know if, I would like to get early warning alerts. So, you know, I think it's a very interesting proposition. This has been a great conversation, man. Your turn, by the way, since I've asked all the questions so far. Do you have any questions for me?
Sure. I'd love to hear from you about, so because you get a chance to speak to a wide range of people in the space, and I'm sure from different kinds of backgrounds, but what kinds of things, what kind of interesting technologies, or what kind of interesting trends do you see emerging, particularly as it relates to physical therapy?
Well, you know, I think the most exciting technology that I've seen in recent months has been about movement tracking. So companies like Tracer, they use a Microsoft Connect or something similar to that. And there's a bunch of other companies doing similar things. Evolve is another company. And And then more recently, we had Anang Chokshi on this podcast, and Anang talked about the new technology from Google. I'm looking it up right now because I always forget the name of it, but it can essentially, instead of, it can use a cell phone, a simple cell phone camera, one camera, and be able to predict movement. So it uses AI to be able to predict movement. It's called Tensorflex. It's a new technology from Google. His company is utilizing something like that for future iterations of their product, which is totally fascinating to me. I mean, basically, I think there's going to be applications in our space in terms of assessing movement and being able to make recommendations to patients and professionals. And of course, there's all kinds of other applications like animation and avatars and other things that I think will just be super cool based on much more realistic movement. So something like a video game is going to look like, I mean, as real as they look already, they're only going to get more and more real looking. To me, that's so fascinating, so unbelievable. Other areas, I think, I think integration, of course, is going to be really important, just integrating technologies and creating a more smooth user interface for patients and providers. We all know how clunky an EMR can be, and having to use a different system for telehealth, and having to use a different system to do movement tracking. If you ever use like I forgot what it's called, Dash, I forgot what it's called, but I used to record patients on my phone, and it could break down their movement. If that was all integrated into one system, which I think that's happening in other areas of healthcare, I think it's definitely happening in PT. It's going to be more and more integrated to make the life of the practitioner a little bit more efficient. So thanks for the question. Great question.
Yeah, you bring up really good points that illustrate the strengths of the sort of commercial players, which are, they have funding.
Yeah.
They have a really good handle on user experience.
Sure.
And they have access to technology, really cutting edge technology. And these three areas traditionally have been lacking in healthcare, right?
Yes.
Most healthcare products, like you said, are clunky.
Yep.
Healthcare systems typically don't have access to a lot of capital, and we don't have access to a lot of technology and the ability to develop new products. Yeah. And I wish in some ideal world somewhere, and maybe COVID will make this happen, these two areas will merge together. I hope that Google's and Apple's and any other large, like Amazon's, partner with clinicians, researchers with practical experience to create products that kind of help to disrupt the system a little bit.
Yeah.
And make things fun to use. When is healthcare really fun? It's never fun, right? Make things.
Oh, it can be fun.
Can be, yeah. Fun to use, easy to use, and designed with the consumer, in this case, the patient.
End user, yeah.
And for us in healthcare to really understand that technology is not all bad. We, like you said, we all have these horror stories with EMRs and killing our productivity and our time we spend with patients, but it can be designed better. And in this case, we would be the consumers, and we would love to contribute to the user experience and make systems that work. So it'll come one day, probably not overnight, but now that with a lot of these technology companies are getting into the space, I'm seeing a lot of these shifts that you have mentioned.
Yes, for sure.
In the right direction.
Yeah, and there are companies who are doing some of the things that you brought up, not just Google and Apple and Amazon. Anang's company, Include Health, is one of them. I met with a company called Evolve, very smooth user interface, and great integration of several components of technology that PTs use. So it's definitely on their mind. The most important thing you said, though, is to have clinicians involved in the development process, because too often technology that is developed for healthcare is developed by technologists or engineers, and they don't necessarily have the right input from the real users. So I think, and I hope that more and more of that is happening. But that's what those are the types of products that end up winning, the ones that are actually designed for and by and for the end user.
Absolutely.
So great point, man. We should definitely do this again. So thank you, Emil. How can people get in touch with you?
I'm on LinkedIn, Emil Berengut. They can email me if they like, eberengut@gmail. If they want to talk population health, physical therapy, motivational interviewing, I'd be happy to connect with folks and talk to them. So
nice. And I hope people do reach out to you, because your wealth of knowledge, you've definitely, you're not just a theorist, you're a practitioner, you've lived it, you're living it now. And I think you can be, you're a great resource for a lot of people out there. So thanks, man. Thanks for coming on the show, and thanks for being such a great sport.
Thanks for having me. And actually, and I'm really grateful for you to be doing this. So thanks for keep doing what you're doing. This is
My
great.
pleasure, man. Thank you. Thank you. All right. See you, Emil.
Bye.